Hello, everyone. It's my pleasure and honor to present the findings of a trial that my study group and I did on the question of tracheostomy timing in severe stroke in patients that are ventilated in the ICU. And the title is SETPOINT2, which is the acronym for stroke-related early tracheostomy versus prolonged orotracheal intubation in neurocritical care, trial number 2. The background is that patients with severe ischemic or hemorrhagic stroke, so stroke by large vessel occlusion or by the rupture of a vessel leading to a brain bleed, very often have dysphagia. They have problems swallowing and they are ventilated in the ICU. And there's a high degree of extubation failure. It's not easy to get their orotracheal tube out, their breathing tube. And many of these have to be tracheostomized. They need a tracheostomy. They need a replacement of the long breathing tube with a short tracheal cannula. And smaller studies proposed benefits to do this tracheostomy earlier, proposing benefits like less laryngeal lesions, less work of breathing, less need of sedation, a shorter duration of ventilation, and then maybe being able to mobilize these patients earlier and send them to rehabilitation earlier, giving them benefits with regard to mortality and morbidity. But nobody knows when is the best time to do the tracheostomy and whether an early tracheostomy really has these proposed benefits. So this is the rough protocol of the SETPOINT2 randomized trial. It's a multicenter probe design trial, and 25 neurocritical care centers in Germany and the United States have enrolled patients in this trial over the last 5 years. The intervention to test is a primary dilational tracheostomy before day 5 from intubation. And the control is the standard common way to try to wean and extubate the patient or else do a tracheostomy on them after day 10. So early versus late tracheostomy in patients with severe stroke that are ventilated. The primary endpoint is long-term functional outcome measured by the modified ranking scale, which assesses motor function in daily activities after 6 months. And for the primary endpoint here, we have dichotomized that score between 0 to 4, which means survival without severe disability, versus score 5 or 6, which means severe disability or death. And the sample size was 380 patients. And I jumped right to the primary outcome. And as you see, there was no difference in survival without severe disability. The modified ranking scores, scale scores were very similar. And we have 43.5% in the early group and 47.1% with bad outcome in the standard group. And that was not a significant difference. And there were also no differences in all sensitivity analysis and no difference in many secondary outcomes with regard to survival, causes of death, ICU course, and safety. So all in all, a neutral result of this trial. And the main conclusion is that among ventilated ICU patients with severe ischemic and hemorrhagic stroke, a strategy of early tracheostomy compared with the standard approach to tracheostomy did not significantly improve functional outcome at 6 months. Thank you very much.